Hello and welcome to the second in our series of the Block Party Regional Anaesthesia talks. I'm Emma Joins and today I'm going to be talking about trunk blocks. If you wouldn't mind just taking 30 seconds to take a picture of this QR code on your phone. It takes to a really short survey and there's one at the start and the end of the lecture just to get an idea of people's baseline knowledge and how useful it is to do this talk. So thanks very much for filling it out. Just give you another few seconds to do that. Okay, so I also just want to say thanks to Matt Hyam, who's annotated some of the ultrasound images for this talk. So the aims of this talk are to refresh your knowledge about some of the commonly performed trunk blocks. I'm going to talk about abdominal wall blocks, namely the rectus sheath block, transversalis abdominis plane block, and chest wall blocks, including the Erector Spinae plane block and the serratus anterior plane block. I'm going to start by talking about the rectus sheath block. So these have been around for a while, and they were first described under ultrasound for using rectus sheath catheters in around 2007, and their use has developed from there. Indications for this block would be for analgesia, for surgery covering the midline, for example, laparotomy. So the anterior rami from the spinal nerve roots of the thoracic nerves, T6 to T12, and also L1, come out and travel in a plane between the internal oblique and transversalis abdominis. They then come behind the rectus muscle, through the rectus sheath at the front to innervate the abdominal wall. You want the patients to be supine with their hands by their sides, generally speaking, for this block, and you can do a one-off bolus, as in the picture in the top left, and you can come in from medial to lateral or lateral to media using a linear probe and positioning above and lateral to the umbilicus for this block. If you want to put in rectus sheath catheters, you'd have your probe positioned like the black and white picture in the middle, and you'd have your probe in a sagittal plane and have your needle coming in from above. Landmarks for this block: if you start in the midline, none of the muscular structures cross the midline. So the linea alba is in the midline of the abdomen, and if you use that as your landmark, you can then scan outwards to the rectus sheath muscles. So you can see the rectus sheath muscles either side of the midline, the rectus sheath muscles, surrounded by the rectus sheath, either side of the linea alba in the midline in this picture. And here you can see that picture again in a video. So you're starting at the linea alba, and we're going to scan out laterally across the rectus muscle. You can see the abdomen and the peritoneal contents moving underneath the rectus muscle, and the hyperechoic white line surrounding it, which is the anterior aspect and posterior aspect of the rectus sheath. It then terminates at the semilunaris membrane, tendinous sort of membrane, before you start to see finger-like projections of the oblique muscles, internal and external, coming into view, and the transversalis abdominis muscle underneath those two, just between the abdominal cavity and the internal oblique. So when you're doing this block, you are going to bring your needle in through the anterior rectus sheath, the rectus muscle, and put your local anaesthetic in between the posterior aspect of the rectus muscle and the rectus sheath. And you normally see the rectus muscle being peeled up off the posterior aspect of the rectus sheath, and local anaesthetic spreading as a dark line between the two layers, something like this. There are some epigastric vessels that can lie in the rectus muscle, or they can lie deep to the rectus sheath. So the superior and inferior epigastric arteries, depending on which side of the umbilicus you are. So they're quite difficult to see without ultrasound, but if you put ultrasound on, they're quite easy to visualize, as in the next picture here. So it's important to check that you're not going through one of these vessels. This picture on the left just highlights the sensory spread for the rectus sheath block, or the TAP block. So you can see the rectus sheath block covers the midline for surgery such as laparotomies. You can see that a classical TAP block bilaterally covers the lower part of the abdomen here, and you can do a subcostal TAP block as well. If you're using rectus sheath catheters, these are connected up to a bag of local anaesthetic, which are the Shaw fusers, and these are kept in the fridge in recovery. With rectus sheath catheters in this trust, we would use epidural catheters to put in bilateral rectus sheath catheters, for example. These would then connect to a Y connector, and that would connect to the Shaw fuser and stay attached to the patient. Again, this diagram highlights the anatomy between the rectus sheath and the TAP block as you move more laterally across the abdomen. On the right side of the screen, you can see the rectus muscle in the rectus sheath, the linea semilunaris, and then the oblique muscles more laterally, the external oblique, the internal oblique, the transversus abdominis muscle, and then the abdominal cavity with its contents below those. Generally speaking, the thickest muscle for the TAP block is the internal oblique muscle, and the thinnest muscle is the transversalis muscle, if you're trying to orientate yourself with the muscles. And this picture on the left is just an annotated diagram for the muscles, and on the right, again, this is a scanning image which shows some skin and subcutaneous tissue or fat, the external oblique, the internal oblique being the thicker muscle of the three layers, and then the transversalis abdominis muscle. And your injection is going to come in, and you're going to put local anaesthetic in between the internal oblique and transversalis abdominis plane, and you can just see the internal oblique peel upwards as you open up the plane and inject local anaesthetic. Typically, I might use 20 mils of 0.25 levobupivacaine either side of the abdomen for this block, but it would depend on the patient's weight and maximum dose. The indications for using a TAP block are for post-operative and also for intraoperative analgesia, for appendectomies and caesarean sections. Again, you want the patient to be supine and to use a linear probe. And the position for doing the block on the abdomen is at the level of the anterior axillary line between the costal margins and the iliac crest. The erector spinae plane block is also one of the more recent blocks to have been described, and this was one of the first papers describing its use in 2016. It's again an interfascial plane block, and it's best placed below the erector spinae muscle to achieve analgesia. It's thought that the block works because the anaesthetic tracks back to the paravertebral space and surrounds the spinal nerve roots. And here you can see the nerves coming out from the paravertebral space, and there's a ventral rami or branch which goes on to supply lateral and cutaneous sensation to the chest wall, and there's a sympathetic branch for the sympathetic chain, and there's a dorsal branch which supplies the erector spinae muscles and the skin to the back. These red dots just show a variety of blocks in this region. You can see the erector spinae block here on the transverse process. The setup for this block, generally speaking, you want your patients to be sat up, as in this picture on the right here, or in a lateral decubitus position. I've found in practice, patients with multiple rib fractures generally are more comfortable in a lateral position and not always able to sit up. You want to use a linear probe for this, but if the transverse process is deeper than 4 centimeters, you could consider using a curvy linear probe to give yourself a better image. And you want to do this as a full sterile technique as you would with an epidural, because of where you're going and the fact that you're using a catheter. Your landmarks for this are the erector spinae muscles and the transverse processes, and I'll show you those on an ultrasound image shortly. And again, it's a large volume block, so you can do it as a bolus, but generally speaking, we would put in catheters, so you can use a 2E needle to do this block. And you can come in from caudal to cranial, as in this picture, or cranial to caudal as well. So looking at the ultrasound picture that we're going to see, you're going to see the erector spinae muscles, as you can see here, over the top of the transverse processes, and they've got a hyperechoic bright white part at the top of the transverse process, and then this dropout, and they look like a rectangle, or are described as a tombstone shape. Here we can see the erector spinae muscles, the erector spinae plane between the muscles and the transverse processes. Underneath the transverse processes, you can see the paravertebral space with the pleura and the lung. You can see that a bit easier in this diagram here, where you'll see the transverse processes come into view, and then the scan is moving outwards. So you can see that tombstone appearance, and might convince yourself the lung is at the bottom as well. And then here you can see these round acoustic shadows, much rounder, which are the ribs. You can see the pleura and then the lung moving below that. And then to convince yourself again, you can then move more medially, and you'll see a dropout where the rib meets the transverse process, and then you'll see the transverse process reappear, and it'll be that tombstone shape again. So when you're putting your local anaesthetic, this is an annotated diagram to demonstrate how it could look. So if you aim for the transverse process, the local anaesthetic can spread anywhere along that plane between the muscle and that potential space where the transverse processes are. But if you use the transverse process as a backstop, then it adds an extra safety barrier for not putting your needle too far when you're starting to learn this procedure. And you want to inject your local anaesthetic here, and again you'll see a black spread of local anaesthetic in this plane, like this. Again, this diagram is just showing how you would have your probe in a sagittal position along the transverse processes between the spinous processes and lamina medially and the ribs laterally, and you'd be seeing this tombstone appearance on your ultrasound, which are the transverse processes sitting below the erector spinae muscles. And this again is highlighting the same thing, but this is showing a block in real time. The needle's coming in here in diagram D, and you can see the local anaesthetic spreading as a black line. It's the same picture as C, which is a bit easier to see when it's not being annotated. I'm going to briefly talk about the serratus anterior plane block, as some people wanted to go over this block as well. So the indications for this block would be for anterior rib fractures from the 2nd to the 9th rib. It's not so good for posterior fractures, and you might consider an erector spinae block for that instead. It can also be used for extensive breast surgery, for instance, in a patient having a latissimus dorsi flap, or for hemithorax surgery. And it covers the axillary region, and it's more lateral and posterior to the PEX 1 and 2 blocks, which are quite similar but in a slightly different location. So the long thoracic nerve comes off the cervical nerve roots to supply the serratus anterior muscle, and it goes between the serratus anterior and latissimus dorsi alongside the thoracodorsal nerve, which supplies latissimus dorsi. So these two nerves run in between the plane that we're going to block. To find the position, you want to have your probe in a coronal plane, as in this picture on the left. And if it's a skinny male, you can use the nipple as a landmark, but you can also count down from the clavicle to find the 5th rib, and then move posterior and lateral until you start to see the latissimus dorsi muscle, which should come into view. You can use a linear probe for this, and you'd plan to come in from below your needle in this picture. In this diagram, it shows how the probe is moved sort of more posterior than the original picture, and so at this point you should start to see latissimus dorsi come into view. Again, you'd have your needle going from inferior to superior, or caudal to cephalad, and on the ultrasound image here, you can see how there are the ribs, which are these hyperechoic structures. You can see the pleura in between those and the lung underneath. On top of the ribs, there's this thick hyperechoic sort of muscle, which is the serratus anterior muscle, and then the thin latissimus dorsi muscle, which is above it. So you want to have your local anaesthetic coming in and going in between the latissimus dorsi muscle and the serratus anterior muscle. And it's again a large volume block, and you can leave in a catheter for analgesia for up to 3 or 4 days. It's useful as well to use Doppler because it's also a vascular area, and you want to avoid injecting or putting a catheter into the thoracodorsal artery, which runs in the same plane as those nerves. So in summary, I've talked about the RA UK trunk blocks. So the Erector Spinae plane block and the rectus sheath block. And I've talked about transversalis abdominis plane blocks and serratus anterior plane blocks. Just before I go, there is an app which I've found quite useful, and it talks about a number of different blocks, and it has short ultrasound images of how to do the block in a few minutes. So if that's useful to anyone, this is the app, and it's from ULM Rehabilitation Clinic have developed it, and it's called RKU Compact. So thanks very much for listening. If you wouldn't mind just filling out the post-lecture survey, just take a minute or so, that would be really useful for us for feedback. There's also information available on regional anaesthesia on the intranet under the anaesthesia guidelines, which you can access via the clinical directorate and the core clinical services. So the anaesthesia guidelines have got regional anaesthesia page, and it does talk about all of these blocks and what kind of local you might use for a bolus or an infusion, the equipment you might use and the indications and so on. Thanks very much for listening.